Hi guys, Jean Marie. What we're going to be talking about today is the care of the patient with cardiac problems. Specifically, we're going to be talking about heart failure. Today, we're going to be talking about the how to prioritize with evidence-based practice to care for patients with common cardiac problems affecting perfusion. We're going to talk about common drug therapies that will improve cardiac output, enhance peripheral perfusion, and prevent worsening of cardiovascular problems. We're going to talk a lot about nursing interventions and nursing care to promote perfusion and prevent complications such as altered gas exchange, altered comfort, and altered immunity. We're also going to look at assessing the signs and symptoms to prioritize nursing care for patients with cardiovascular problems. Then we're going to talk about transition care and patient education. Before we start talking about heart failure, I believe it's important for us to take a brief moment and discuss some of the anatomy and physiology of the heart and the pathophysiology of the heart. Now, this is by no means a everything that you need to know about the heart, but these are just some things that I think it's important for us to take at least a moment to look at. So first, we're going to look at preload. Okay, before we talk about heart failure, I want us to take a very brief review of both anatomy and physiology and pathophysiology of the heart. This is by no means a full lecture on that. It is just the down and dirty. And it is by no means everything that you would learn from reading chapter 33. So preload is the degree of stretch of the myocardial fiber at the end of diastole, just before it contracts. So what exactly does that mean? Well, what exactly does that mean as far as with heart failure? So with preload being the degree to which the myocardial muscle fiber is at the end of diastole, what it means is when you have an increase in the amount of volume in that ventricular volume, the muscle fiber continues to increase. And at first, with the increase, it's able to snap back and it increases the contraction. And with that, it improves the stroke volume until it doesn't. And the reason it doesn't is because of excessive filling of that ventricle, meaning that it's been doing it so long and now it's gotten floppy. The excessive filling of the ventricle results in excessive left ventricular end diastole volume, meaning that even after it's at full stretch, it has more volume and pressure, which actually leads to a decrease in the cardiac output. Afterload is the pressure the ventricles must overcome to eject blood through the semilunar valves and into the peripheral vessels. The amount of resistance is directly related to the arterial pressure and the diameter of the blood vessels. Now, contractility is the cardiac contraction's force, and it is independent of preload. Contractility is increased by factors such as sympathetic stimuli, calcium release, positive inotropic drugs, and is decreased by acidosis and hypoxia. So let's just take 2 seconds and think about our heart failure patient. We know that they're going to be on positive inotropic drugs, but they're also going to have times of hypoxia. So therefore, it would decrease their contractility. Cardiac output is the amount of blood that is pumped from the left ventricle each minute. So it's heart rate times stroke volume. And remember, stroke volume is the amount of blood ejected by the left ventricle with each contraction. Now, ejection fraction, you'll hear a lot about that when you're talking about patients with heart failure. And that is the percentage of blood ejected from the heart during systole. So it's the actual amount of the blood that actually goes out during systole. So that's important to know. And the reason that ejection fraction is important to know is because, we don't eject all of our blood with each contraction. The normal ejection fraction is about 55% or higher. When a person has less than 40%, they are considered to have heart failure. So that's where that comes into play. And you'll see where ejection fractions are used. You'll see them, they usually get them off of an echocardiogram, which is where they do an ultrasound of the heart looking at blood flow. And that will help them to determine what the ejection fraction is for a patient with heart failure. Heart failure or pump failure, it is a general term used for the inability of the heart to pump efficient blood to meet the needs of tissue and nutrients. And a lot of times these patients do not have normal sized hearts. They do have cardiomegaly. And that's because that, especially that left ventricle has been stretched. So it doesn't have good contractility, lowering their ejection fraction. I hope that makes sense. Okay. Fast facts about heart failure. Heart failure patients take on average of 6 medications. So patient education and identification of resources is extremely important for the discharging nurse and for the care coordinator. 78% have at least 2 to 3 hospitalizations, admissions per year. And we'll talk about it here shortly, where if they are admitted within a too short a period of time, Medicare will not reimburse the hospital for the readmission. 50% of heart failure patients have 3 or more comorbidities. 500 to 700,000 new cases annually, and it doubles with each decade due to increased obesity, lifestyle choices as far as having a sedentary lifestyle, their choices of eating habits. And another reason, even people who are healthy as far as their eating and their weight, people are living longer. So basically your heart, the pump just starts to give out. It is the most common cause of hospitalization for patients greater than 65. Risk factors for increasing the chance of developing heart failure include history of an MI, hypertension, diabetes, being African American, but also the increased obesity, the lifestyle choices, and really just the fact that people are living longer also has caused the rate of heart failure to increase in the United States. It is going to be very important for you to look at. It's going to be important for us to look at Table 35.2 under Meeting the Healthy People 2020 Objectives on page 695. One of the ones that brings to light is if the patient is discharged home from the hospital, call to check that he or she has no impending signs or symptoms of heart failure. The case manager may make these calls. And that's very important because with the new JCAHO requirements that the hospitals may not get reimbursed for hospitalizations for heart failure that have been less than 30 days, the follow-up care for these patients is extremely important, making sure that they understand when their follow-up visits are, and making sure that they're aware of what the signs and symptoms of worsening heart failure is in order to seek treatment. So make sure that you look over the that table 35.2 on page 695. So heart failure etiology or cause, they are all listed very nicely for you on page 694 in table 35.1. But some of them are systemic hypertension, coronary artery disease. With that, sometimes people will have episodes of acute heart failure during with a acute MI. when patients have cardiac infection or inflammation, more chronic conditions such as cardiomyopathy, valvular dysfunction, either with the pulmonic or aortic stenosis, can all lead to heart failure. Again, that table 35.1 on page 695 will be important to look at. And here, I basically just kind of divided up that table 35.1. And this is just the risk factors for heart failure. It's patients with dysrhythmias, diabetes, substance abuse, including smoking, alcohol abuse, or illicit drug use, family history, obesity, severe lung disease such as COPD, and sleep apnea. Diagnostic tests for heart failure. Some of these are lab tests, such as the BNP, because it is released by the ventricles when the person has fluid overload, such as with heart failure. Of course, we're going to do serum electrolytes, a urinalysis, BNP, creatinine. Sometimes the patients will have lung function testing. They will have ABGs done, especially if they are hypoxic. A chest x-ray. Now, a chest x-ray is twofold. Not only will it show cardiomegaly, but it will also show if we're having left-sided heart failure, which we'll learn about here in a few minutes, you will see the congestion in the lungs. The patient will get an EKG to look for changes. The patient may get an echocardiogram, which is an ultrasound of the heart, looking at blood flow and volumes. A TEE is a transesophageal echo, and it's doing the same thing as a traditional echo, which is with the traditional echo, they're putting an ultrasound gel on the chest. With a TEE, it's the transesophageal echo. They're placing it, the echocardiogram probe down into the esophagus. So naturally, the patient is under conscious sedation. There is a CRNA there. Of course, the echo tech running the machine. There is another ACLS nurse and the cardiologist. The funny thing with a TEE, one of the things they do is a bubble study. And what that is where you take two 10C syringes with only 5 cc's of normal saline, and you put them between a stopcock and you push them back and forth, which actually creates bubbles. And then at the order of the physician, you push it very fast, very hard into a peripheral IV. And so then the doctor or he or she can watch this cascade of bubbles going through the heart. And what that does is he or she can see the blood flow more clearly because you have this little cascade of bubbles. And you can also see if there is any retrograde. Do the little bubbles go back up? Which can show valvular problems, which is very interesting to watch. And sometimes these patients will also have a cardiac catheterization. We'll get into the different types and classifications of heart failure in our next set of videos.